if you would prefer us having questions at the end, or should the guys maybe interact with you during the course of your presentation, how would you prefer it?
Thank you, Gerard. I would prefer if we interact throughout the presentation by raise of hand.
Okay, 100%. So what I'll do is because you're obviously going to be presenting, so what I'll do is I'll be on the lookout for raise of hand, and I will then just interrupt you when there is a hand. So please, everybody, feel free to interact during the course of the presentation. That's what this is all about. It's for ourselves and to gain knowledge. So yeah, please do. So, Doctor, I think over to you. Yeah, we're keen to hear what you have to say. So you can share your screen, and then we can go from there. Thank you.
Okay, please give me a second. I'm just trying to open my presentation.
No problem.
Gerard, if I can just come in, the link is working now.
Okay, thank you very much.
That registered so they can use it.
Okay, thank you very much. So please, everybody, use that link. It's the last link. Yeah, so please make sure that you complete the attendance register as well. Thank you.
Okay, thank you very much, Gerard. While we are just waiting for my presentation to open, it seems to be taking time. I would just like to add on what you have said. I'm an occupational medical practitioner, obviously a general practitioner by training, who specialized in occupational medicine. I have also specialized in travel medicine. I hold a certificate in economic risk assessment, and I'm also an exposure scientist. Exposure science is just a new field that has just been introduced in our country, incorporating occupational health and safety, occupational medicine, environmental health, and occupational hygiene. Let's just look at what's happening. Annelien, do you mind loading the presentation for me? I've just sent you the final presentation via email. I'm not sure if you've received it.
I did. I'll open it for you.
Okay. And I'll just indicate when you need to move the slide. Okay, if you don't mind sharing, please go ahead and share. Yes, I was just saying that there is a rest nowadays to move from the isolation of occupational hygiene and occupational health and economics and occupational health and safety. So recently, exposure science was introduced in our country. It's very huge in Europe and Australia and the West, with a view of incorporating everything, because people have realized that we work in silos. You know, occupational health will do what they do, occupational hygiene will do what they do, occupational health and safety will do what they do. Sometimes we don't consolidate our work or our findings, you know, for the benefit of the workplace. All right, thank you, Annelien. All right, let's go through the overview of today's presentation. We will first look at the legal framework that enables us to work as occupational health workers within the industries. And then we'll look into who plays the role within the occupational health space in terms of healthcare workers. Then we'll delve deeper into what is occupational health and what are the implications within the working environment. We'll also look at the two major components of occupational health, which is risk assessment and management and medical surveillance. I'll also go through with you the other important roles that occupational healthcare workers do within the occupational health space or within the working environment. We'll go through the occupational health service setup in South Africa. We'll look into various models that are in practice in our country. And then I'll go through briefly occupational health as applied in or within the agricultural sector. And then we'll go through a case study that I would like to share with you to demonstrate how we normally solve the problem or how we normally approach issues within occupational health. And as we have mentioned, questions are welcome at any stage during the presentation by raise of hand. The common laws that usually enable us to practice occupational health are Occupational Health and Safety Act, and I think that's the main reason why we exist. There is Occupational Compensation of Occupational Injuries and Diseases Act, also known as COIDA. There is Labor Relations Act, which we often have to advise companies from time to time in terms of applying in certain circumstances. We'll go through this in detail in the next slides. And then the other common one is Road Traffic Management Act, which we often apply in licensing for drivers, heavy machinery drivers, and operators. Just for interest's sake, within the mining sector, we have what we call Mine Health and Safety Act. It's actually the Occupational Health and Safety Act version that is applied in mines. And then we have ODMUA, they call it ODMUA. That's the Compensation of Occupational Injuries and Diseases Act as applied in mines. And obviously, Labor Relations Act applies in its original form. In terms of Occupational Health and Safety Act, we are usually supported by Section 8, which describes the responsibilities of the employers, for managing risk and ensuring employee safety within the workplace. If I quote the Department of Labor, it says Section 8 of the Occupational Health and Safety Act places the onus on employers to ensure that working environment is safe and without risks and to health and of their employees. In order to accomplish this, employers must, through the services of a competent person, assess the exposure of the employees to hazardous environmental conditions in the workplace. And in addition to that, when the word competent person is used a lot throughout Occupational Health and Safety Act, and sometimes Compensation of Injuries and Diseases Act. A competent person is a person who is properly qualified, and I would say by experience and academically, to perform a certain function. And this also applies, when we talk about risk assessments. Recently, I've seen that even in economic risk assessments, they usually say a competent person must perform that important function. So while we are still on that slide, in support of Occupational Health and Safety Act and Compensation of Occupational Diseases and Injuries and Diseases Act. I'll mention just a few that are relevant within the farming industry. And then we have also regulations under Occupational Health and Safety Act that support the Act. You know, they usually go into deeper details in terms of managing specific issues within the workplace. Annelien, if I may ask you to go back to the main slide, that the one before that one. All right. Yes. No. Go forward. Yes, that one. So in terms of Occupational Injuries and Diseases Act, QUIDA, the Occupational Health Service or the clinic or occupational health care workers play a role in facilitating the referrals. And as we know, the Act or the facility through the Compensation Commission acts as an insurance for occupational injuries. And the major advantage of this for employers is that employers are protected in terms of this Act from being held personally or privately liable for occupational injuries, meaning that as a South African company registered in terms of QUIDA, it is not possible for employees to personally or to privately sue the company for the injuries that occur in the workplace. Compensation Commission acts as the insurer in this case and pays for all the medical bills and sometimes the compensation wherever is applicable. So in terms of the compensation, we have temporary disability that is usually compensated. That is usually patients or employees that are injured and take up to 2 years to recover. And then we have permanent incapacity or permanent disability for people who fail to recover after 2 years. The 2 years is the cut-off, and in terms of insurance principles and also POID, usually an illness or an injury that continues after 2 years is considered a permanent injury. So that's what determines whether this is a temporary or a permanent incapacity. In terms of other benefits, there is a death benefit that is administered in terms of the Act through Compensation Commission for the benefits of the dependents if the employee dies during the discharging of his occupational responsibilities. I see a hand.
Doctor, it's just mine. So just for clarity's sake, in terms of declaring a employee permanently disabled or disablement, so is that done by the occupational medical practitioner, or is that done by the compensation fund, or who determines that aspect?
Thank you, Gerard. That's a very important question. I think it depends on the occupational health setup of a company. For companies that have an occupational clinic, normally the treating physician or the specialist will declare an employee fit to work, but that is usually a recommendation if there is a clinic on site or if the company operates its own clinic, which will have the final say. So in that setting, the occupational health team will decide based on their knowledge of the workplace and the kind of environment the employee works within, will decide if the employee is fit to work or not. But in a setting where there is no occupational health clinic, usually the company is guided by the treating physician. And also the Department of Labor Compensation Commission follows the lead of the treating physician. So I would say between the treating physician or the treating doctor and the occupational health team on site, those are the two people that would decide when the employee is fit to work. Thank you, Gerard.
Thank you.
Yes, so yeah, in terms of the Labor Relations Act, as the clinic or as the occupational health service, we normally support the company or the HR in facilitating certain types of leaves. And I can think of maternity leave. Would normally recommend when an employee is due for a maternity leave, or sometimes when an employee needs to go on an early maternity leave due to medical conditions. And then we'll normally advise on terminations as a result of incapacity. And then this also enables us to help the company or the HR to facilitate certain types of work conditions or leaves that are not otherwise not easy to facilitate, especially if they involve medical conditions or disability or incapacity. And then in terms of Road Traffic Management Act, we assist in the process of licensing. One thing I can think of that's commonly done is a PDP medical. This is equivalent to a normal medical that is done in a company. It's just that the legal system allows it to be done by a normal GP or a normal doctor who's not really an occupational healthcare worker, but a PDP is seen as a medical because at the end of the examination, an employee is declared fit to drive for public or for consumer good. And then in terms of the South African Society of Occupational Medicine, we have classifications of drivers by profession. We have class 1, which is people that drive hazardous chemical substances. You know, this is your fuels and your explosives and your gas. And then we have class 2, which will be heavy vehicle drivers. And then we have class 3, which would be anybody that drives a company car. So most of us, we are class 3s if we are allowed to drive company cars. And then obviously this still needs to be amended. You have class 4, which will be your forklift drivers and machinery drivers, machinery operators. So the drivers that are licensed to operate on national roads or provincial roads obviously have to be licensed in terms of Road Traffic Management Act. Annelien, may I please ask you to proceed to the next slide? And the next one, we have covered Occupational Injuries and Diseases Act also. And we said we do the management of IODs within the clinic, the previous one, within the clinic where we decide who needs to be referred outside and who needs to be managed inside. So meaning mild injuries can be managed within the premises if there is an occupational clinic or there is a nurse or a doctor on site. And this will help to minimize unnecessary injuries. I think we call them lost time injuries. So this will help manage that. And then we also liaise with external healthcare providers like specialists or treating doctors in terms of the progress of the illness or the injury, in terms of operations and procedures that need to be done, and also in terms of recommendations for placement or accommodation into the workplace. Remember, these treating physicians or doctors or specialists normally don't have an idea what kind of environment the employee works within. So most of the times they will just say, go back and do light duty. And sometimes employers will tell you that, and I think it's their biggest headache, that we don't have light duty within this department or within this environment. And that's where we come in. And then, like Gerard has asked, we do what we call return to work medicals. When an employee recovers and needs to come back to work, for that final decision to be made, whether the employee is fit to work or not, we have what we call the return to work medical, and we can also advise on the placement of the employee. Next slide, Annelien. And we've already covered the Labor Relations Act. We do absenteeism management, meaning if you have an employee that you suspect might be missing work, deliberately, or abusing sick leave, or maybe might be suffering for a serious illness, causing his frequent absenteeism or prolonged absenteeism, that's where we come in to investigate and make a final recommendation. And then we advise on leave management in terms of IODs and in terms of maternity. And then we advise on terminations in terms of incapacity as well. And we've already covered Road Traffic Management Act. And then in terms of different instructions, we have about 10 or more different instructions. And the main purpose is to guide the compensation for specific illnesses and for the diagnosis and management of these illnesses within the workplace. Let me park it here and allow Marie to ask a question.
Good morning. Good morning, all the attendants. I just want to clarify something. You not spoke about the Road Traffic Act. I just want to ask, what is if we can just take and elaborate a bit on the licensing.
Yes.
How do you define if somebody drives a company car? What does the company need to have in place, and what is the responsibility of the driver?
All right. Thank you very much. A company will usually appoint a person as a driver, or in a certain role, assign a company car. And when we do our risk assessment in terms of that person's job spec, it will be listed that this person is also a driver of a company vehicle. And normally, apart from the normal PDP that is required by the Department of Labor, in the medical that we do, the medical assessment that we do, be it the pre-employment or routine medical, certain tests will be done to determine whether this person is fit to drive. And this forms the basis of when we complete the PDP examination, because it asks about all the conditions that can potentially affect driving and safety during driving. But unfortunately, and I use the word unfortunately intentionally, because in South Africa, this is one aspect that is not really universalized. You have the Department of Labor just expecting you to complete one form for them to allow the person to have a PDP. And that also applies to taxi drivers and people, PDP, I think it stands for public driving permit. But
yes.
Yeah, so it's a broad term that covers both people in the workplace and people who use certain vehicles to transport the public. But within the workspace, we have what we call a driver's medical, and that's not necessarily a PDP. I think in terms of our requirements from the Department of Labor, we do a risk-based medical assessment. And because we know that this person is a driver, even if he doesn't have a PDP, say for instance, a driver on a farm who drives a company van to go to the fields and sometimes to go feed the animals will not necessarily have a PDP. But in terms of Occupational Health and Safety Act, he should have a medical that indicates that he's a driver. And in terms of that medical, certain tests have to be done on him. And one common test that we do on drivers is a vision screening, an electronic vision screening that will assess the near vision, far vision, depth perception, and the night vision. So I don't know if that answers the question, Mary.
If I can just give you a bit of a view, in our setting, we've got a office driver who does all the logistics for the office, being it procurement, being it maintenance procurement. Sometimes collecting people from the airport, bringing them to the office to come and attend meetings, taking them back to the airport or to and from their accommodation. Does this person also need to have a medical on file?
Yes. In terms of the law, every employee needs to have a medical on file. And depending on the risk exposure profile, which we'll discuss in the next few slides,
yes,
that medical needs to be based on that. But I would say if you are saying this person goes to the airport to collect certain people, one important requirement I can think of is the PDP. This person needs to have a PDP because he drives important guests for the company and he drives as a professional driver. Yes.
Is there a maximum or a minimum amount of people that needs to be transported for somebody to have a PDP?
No, not that I can think of. I think the principle is that if you drive on public roads on a professional capacity, then you need to have a PDP to cover yourself and to prove that you are qualified to be driving there. Remember, not every driver has a good vision, not every driver has a good condition. So this is intended to manage the risk. The risk of you being involved in an accident and maybe killing an important person, it always goes back to the medical, whether you have a PDP or not.
I've just got 2 or 3 more questions and then I will stand back. I just want to ask quickly. A company employee who drives a company car as, for instance, a manager or an employee who travels to visit farmers and attend to market meetings, etc., etc. What is the legislation around that?
I think these people ideally would still have PDPs, but I don't think it's a common practice to apply for PDPs on their behalf. And the sad thing is our Department of Labor usually struggles to enforce certain legislations. So this is one of the things we normally able to get away with. But, you know, in strictly speaking, this person would have a PDP. And this person would normally have a medical on file that enables him to drive professionally. So I think internally, even if you don't do the PDP, which I strongly recommend, at least this person should have a medical that also indicates or lists driving as one of his functions.
Okay. Just my last question, and then I will stand back. In terms of vehicles going on the road, and also in terms of employees working on farms, when we did our risk assessment, I found that for me, risks are sending somebody in a company car on the road without first aid kits in the vehicle and without fire extinguishers in the vehicle. Is that compulsory?
Yes, a risk assessment is compulsory because that gives you an idea of potential problems that you may need to deal with within a specific industry. And it also enables you to come up with plans to avert the risk or manage the risk.
No, I'm clear on that. I think my question was that if you send an employee on the road with a company vehicle, is it company responsibility to ensure that there is a safety kit and a fire extinguisher in that vehicle?
I would say yes.
And when a person, sorry?
If you're anticipating a potential risk of fire or a potential accident, or it's always a good thing to have those things, even though it's not commonly done. Remember, it goes back to the Section 8 that I spoke about. The employer has a responsibility to determine the risk and come up with reasonable controls to manage the risk.
To mitigate,
so that forms part of the risk management.
Okay. Then just the last thing, that when an employee goes to a farm, and I mean, obviously from a cost point of view for any company, I mean, having to, sorry, just before I go there, if a person travels in their personal car, is it still the company's responsibility to provide any OSH equipment to mitigate risk in terms of a safety kit and a fire extinguisher?
Yes, only if he's expected to travel in his personal car to go and perform his tasks or to go and perform his duties.
Okay.
So if he's allowed to drive his car to the other farms, and it's anticipated that while performing his work, he might encounter a certain incident where those two items would be handy, then the company still has the responsibility to provide.
Okay. And then my last question, and then I'll be very grateful and I'll stand back. Same thing with antidote and protective wear for visiting farms and harvesting trials. If you put an employee on a field to harvest a trial and there is a risk of being bitten by a snake, is it the company's responsibility to protect that employee as far as possible?
Yes, in terms of personal protective equipment and in terms of other risk management procedures. So it is the company's responsibility to make sure the employee is protected. But as you know, should the protection fail or the risk management strategies fail, there is COID that will take over the management of the employee. But obviously, as the company, you need to show that you have done reasonably required or possible measures to protect the employee.
Okay. All right. Now, I thank you very much. That was quite informative.
You're welcome.
I'm very thankful. Thanks. Thank you very much.
Thank you, Mary. Okay. In terms of the instructions, I've picked the 4. I said there are at least 10 or more instructions that we normally apply when managing certain conditions in the workplace. The 4 that I think may be very much applicable to the farming industry is instruction 171, which guides the management of noise-induced hearing loss and the testing of hearing within the workspace. And then we have instruction 176, which governs the diagnosis of occupational asthma and the compensation thereof. And then we have instruction 180, which has become very much important in the recent months. It governs what we call RELDS. RELDS stands for RELDS as in WRULDS. It stands for work-related upper limb disorders. These are ergonomic injuries that occur when people are doing certain manual work or certain physically straining work. I'm talking about your normal back pain that pickers will experience after picking mealies or picking anything from the fields, or after or technicians and engineering people will experience due to working in confined spaces as a result of awkward posture. I'll go through some of the hazards in the next slides. And lastly, there is also what we call work-aggravated asthma. This is an asthma, and it's very important because an employer will be quick to say, but this guy already had asthma when he came in. there is a condition called work-aggravated asthma, which we normally diagnose when the employee is known to have had asthma before he was employed, but for some reason, an exposure to certain allergens or certain substances in the workplace, I can think of soya and gluten within the farming industry, will exacerbate this person's asthma, meaning this is asthma that was normally controlled, but for some reason it gets worse when he's working because of what he's exposed to. And then in terms of regulations, we have many regulations that govern, certain hazards or certain risks in the workplace. You have working at heights regulations, but for the purpose of our presentation today, I just wanted to go to code driven machinery regulations, which would include forklifts and any other machines that are operated within the farming industry. There is what we call hazardous biological agents regulations. This will govern possible infections within the farming industry and other industries, like infections that you can get. HIV falls under this if you're a healthcare worker. Fungal infections, if you work with wood and other substances, will fall under this. And then you'll have hazardous chemical agents regulations, which would include various chemicals that people are exposed to in the occupational health environment. And one common example is organophosphate poisoning that people experience within the working environment, within the farming environment. Annelien, may I please ask you to proceed to the next slide? And last but not least, most importantly, I wanted to share the World Health Organization definition of what occupational health is, which is an area of work within public health to promote and maintain highest degree of physical, mental, and social well-being of workers in all occupations. When they say a part of public health, we have a medical specialty called public health. And public health involves primary health care. That's your clinics in the working and your clinics in the public domain, your small level hospitals, and then you have epidemiology and many other branches of public health, and occupational health is one of them. And then somebody would ask, what is the difference between occupational health and occupational medicine? And we'll start by defining what occupational medicine is, which is a branch of medicine which is concerned with the maintenance of health in the workplace, including prevention and treatment of diseases and injuries, with secondary objectives of maintaining and increasing productivity and social adjustment in the workplace. The main and primary aim of occupational medicine or occupational health is to make sure you have healthy workforce. It's not really to treat flu or diarrhea or manage manage hypertension and diabetes, but sometimes there is an overlapping between occupational health and primary health, because sometimes you may need to treat the blood pressure and the diabetes in order to have a healthy employee. Hence, some companies will have a primary health clinic, which also doubles as an occupational health clinic. And then occupational health, if I just elaborate on the difference between occupational health and occupational medicine. Occupational health is an umbrella term that encompasses everything that has to do with health within the work environment. And that also includes occupational medicine. Occupational medicine is just a medical specialty, but an occupational health term encompasses everything that has to do with health, including occupational medicine. If we move over to the next slide, the common role players in the occupational health system would include what we call an OMP, that's an occupational medical practitioner like myself. In terms of the Department of Labor's definition, an OMP is an occupational medical practitioner who has an additional qualification in occupational medicine that enables them to be appointed in the workplace in terms of Occupational Health and Safety Act. That means, legally speaking, you cannot appoint a GP as an occupational medical practitioner simply because he does not have the occupational health qualification and they have not been trained to function within that space optimally. Yes, they can treat people who are sick, but when it comes to, intense requirements of the job like medical surveillance and medical and risk assessment and management, they are not qualified to do that, and their medicals may not be acceptable when you need to use them as evidence, say in the case of occupational injuries, or let's say if the Department of Labor is investigating the company for any reason. Those medicals would not be deemed valid if they are not signed by an occupational health nurse or where applicable by an occupational medical practitioner. And then we have what we call an occupational health nursing practitioner. We usually refer to them as OHNPs. This is a nurse, a registered nurse by profession who holds an additional qualification in occupational health and is qualified to conduct medical surveillance within the working environment. This is very important because occupational health nursing practitioners are the first people you encounter within the occupational health system. They do all the heavy lifting. They do the occupational medical surveillance. They assist with risk assessment and management. And most companies will have a full-time occupational nurse that takes care of everybody within the environment. And obviously supported by the OMP. The OMP's role would be, as an expert, the leader within the field who mainly makes certain decisions that the occupational nurse cannot make. The liability lies with the occupational medical practitioner, meaning if I say somebody is fit to work and something happens that proves otherwise, I'm professionally liable for that person, which is why we are usually hesitant to just sign if we don't trust who has done the medical, because ultimately by signing the fitness certificate, you are taking the responsibility. We do, in terms of, because doctors prescribe, in terms of prescribing, we prescribe medical surveillance. So I can say, instead of doing a medical on this person every year, please do it every 3 months. That would be my prescription based on the risk. And I can say, in terms of doing a risk management or risk assessment in this department, due to the hazard profile, please do it every 6 months. So we prescribe basically medical surveillance and risk assessment. Before I go to Gerard, I just want to explain the role of a technician before I lose my trail of thought. These are people that are trained to support occupational medical practitioners and nurses within the workplace. Usually they will be trained to do what we call hearing tests, lung function tests, and vision screening. I personally believe they need to be trained in terms of admin as well, but unfortunately, currently that's not part of the curriculum. But they support us in terms of delivering the occupational health in the workspace. And they hold a SHEQ registration. SHEQ is South African Society of Occupational Health Nursing. So they are registered by SHEQ to be able to do audiometry or hearing tests. And this is done in terms of instruction 171 that we have spoken about in the last few slides. They do conduct the testing and they do administration, because it's basically there are no tests to be done. He can't just sit down and do nothing. Hence, we normally ask them to do admin. I'll pause here and allow Gerard to ask a question.
So, Doctor, maybe not a question, just a remark. I think the this is where the collaboration between the occupational medical practitioners and the occupational hygienists and the SHEQ practitioners is very important in terms of conducting the risk assessments together. Because through the risk assessments, you then analyze your risk and can then determine what type of medicals and what health risks you have. That's then incorporated in the medicals itself. So I maybe just wanted to make that remark as well.
Yes. We're still going to explain the collaboration in the next, I think in the next 1 or 2 slides. But thank you, Gerard. That's a very good point. Here we're just explaining the people who form part of the occupational health team, like in the clinic. But like Gerard has said, it's wider, and I believe it needs to be wider than just the clinic, because we do have the support team professionals who enables us to do our work much easier and efficiently. And then the difference between the primary healthcare clinic and occupational clinic. Primary healthcare clinic is, normally deals with treating minor ailments. And in terms of the law, a primary healthcare clinic is not mandated within the work environment, meaning you don't really have to have one. You can function without it, and your employees will still go to the public clinic or a private clinic nearby. The reason why most companies will have a primary healthcare clinic is to minimize absenteeism and to make sure we manage minor ailments internally without having to refer people and without having to lose the shift time. On the next slide, we define the legal mandate for occupational healthcare workers, which is 2 things: the risk assessment, which includes risk management and medical surveillance. And then we have other responsibilities that we normally do within the clinics, which is medical incapacity, injuries on duty, and general health advisory for the company. We'll delve into much deeper details in terms of risk assessment and medical surveillance in the next slide. Risk assessment by simple definition. Please proceed, Annalie. By simple definition is one of the scientific and systematic ways of determining, quantifying, and managing risk to achieve safety in the workplace. We have different risk assessments that are done in the workplace. It goes much deeper than this, but the 2 basic differences is a qualitative risk assessment and quantitative risk assessment. Qualitative risk assessment is a normal walkabout that a clinic team will do and say, there's too much noise here, there's dust there, this thing could trip a person. That's qualitative. Quantitative goes deeper in terms of measuring how much and what is the extent of a risk from a hazard. So meaning in terms of noise, a quantitative risk assessment will measure exactly how many decibels the noise is, how much dust particles per cubic square meter there is, how much concentration of a chemical within a certain environment there is. And the role players in terms of risk assessment, as Gerard has pointed out, the SHEQ team normally does what we call safety audits. These are very important in terms of establishing the risk profile for a company. They do what they call a regular SHEQ audit or safety audit. Occupational hygienists, once at least every 2 years in terms of the legislation, they will do occupational hygiene assessments. And occupational hygiene assessments vary in terms of the risk profile at a company. You have a noise survey, which measures, noise and classifies certain areas in terms of their noise exposure. From this, some areas will be called noise zones. And then you have a dust survey that will be done to measure the amount of dust, and risky areas will be classified accordingly also. You have an illumination survey, which determines the quality of lighting in different spaces. You have indoor air quality and outdoor air quality survey, which basically measures the amount of carbon dioxide within a certain environment. And then you have ventilation survey. There are many. These are the common ones that I think may be applicable within certain farming, different farming environments. And then you have what we call an occupational health risk assessment, which would be done by the occupational medical practitioner and the occupational health nurse. And in addition to what our colleagues do, we consolidate everything that they do to produce what we call a health risk assessment for the company. And from that, we will draw recommendations for the management and for the health and safety team to manage certain hazards and risks. Moving on to the next slide, I just want to outline the risk assessment process, which is normally, as per legislation, required to be done at least every 2 years, but it can be done much more frequently on the instruction of the occupational medical practitioner based on the hazard profile or the risk profile. It starts with, before we do the walkabout, normally it starts with analyzing what we have on record. We call this a desktop risk assessment. So meaning the occupational medical practitioner will go through the safety audits within the past 2 years or so, and the occupational hygiene surveys to get an idea of what to expect when we do a walkabout. And then the next step will be a walkabout where we physically go into a workspace, assess possible hazards and the effectiveness of solutions that are there. It's not only about identifying hazards, it's also about analyzing or assessing the effectiveness of solutions that are already in place or controls. And then from there, we will quantify the risk. Normally, because this is a qualitative risk assessment, will normally quantify in terms of the severity from very mild to very severe. We'll go through the risk matrix later to show how we normally decide which hazard is very severe, which one is very mild. And then from there, we'll recommend the controls, and there, where possible or where required, we will facilitate the actioning or the implementation of controls in support of the occupational health and safety team. And then one important question is the difference between the risk and a hazard. Normally, a hazard is any substance or an object or situation or condition that may pose an adverse outcome on a health status of an employee. And a risk is the likelihood that a hazard will pose that risk, that outcome. So the risk basically determines the likelihood of the hazard posing the outcome. And the hazard is actually the danger that the employee might encounter within the workplace. We have 5 different types of hazards, or 5 different groups. We have physical hazards, which normally cause physical injuries. The examples, let's go through the hazards first. We have the physical hazards, we have chemical hazards, we have biological hazards, we have ergonomic hazards, And then we have psychosocial hazards. Common examples of physical hazards that may cause physical trauma is trauma itself, like physical injuries, amputations, being bumped by moving vehicles. Noise is a physical hazard. Vibration is a physical hazard. Extreme weather conditions, whether it's hotness or coldness, heat or coldness, hot surfaces, walking into freezers sometimes. These are all physical hazards, and there are many. Anything that could potentially cause physical harm is a physical hazard. Assault or physical trauma inflicted by other people is also a physical hazard. We have chemical hazards that could pose injuries to either the skin, the respiratory tract, or the digestive system if ingested. And these are mostly chemicals, different chemicals that are used within the working environment. We have hydrocarbons like your petrol, your diesel fumes. And then we have solvents like benzene, toluene. We have pesticides, especially in the farming environment, like pyrethroids and organophosphates. These are all chemical hazards that people encounter. Then we have biological hazards, examples, any bacteria that could infect a person within the workspace. Flu can be a biological hazard for a healthcare worker or for anybody that is not taking adequate preventative strategies. We have bacteria, we have viruses, we have parasites that people may encounter in the workplace. And then we have fungal infections. I have seen a company that makes your favorite jams and baked beans and things like that, with at least 9 out of 10 people that make jam having fungal infections of their nails, simply because after the fruit has been cooked, obviously fruit is sweet. It has lumps that needs to be broken down by hand. And as a result, sugar will linger, in the finger and nail spaces for a long time, attracting funguses, and then you end up having fungal infections in those employees. So anything can happen anywhere. And then you have psychosocial hazards. Typical examples would be stressful environment, meeting deadlines, and we normally experience this in executive workers or office employees. Post-traumatic stress disorders for people who witness severe or catastrophic injuries or events. We have burnout as a psychosocial stressor, people who are simply overworked, and sometimes for some reason your line manager still feels you're not doing enough. And then we have toxic environments, we have shift work as part of psychosocial stressors. At this point, I would like to invite some questions. I suspect there might be a burning question regarding hazards or...
Doctor, maybe just from my side quickly, what would your opinion be in terms of would it be better to keep the occupational health risk assessment on its own, or would you say that it would be more beneficial to incorporate the occupational health risk assessment with the occupational safety risk assessment? Can you hear me? Sorry, can anybody else hear me?
We can hear you, yeah?
Yes,
Yes.
we can hear you. What if he's not on mute, Gerard?
Okay, I see Doctor just sent me a message now. He's just reconnecting. He disconnected. Sorry, let's just wait for him to reconnect.
Maybe the infamous load shedding.
Yeah, no, he says it is load shedding, so it's up and down.
Can you hear me, Jared?
Yes, there we go. We can hear you again.
100%.
No problem, no problem.
Cut. Yes.
Did you hear my question?
No, I didn't hear the question.
Okay. So my question was in your opinion, what would you say is better? Do we keep the occupational health risk assessment on its own, or is it better for us to incorporate the occupational health risk assessment with the occupational safety risk assessments?
I think it depends on the occupational health makeup of the company. If you have an occupational health team that is usually available when the health and safety audits are done, it would be a nice and a very helpful exercise to collaborate, because sometimes what occupational health people recognize as a hazard might be clarified by the occupational health team, and vice versa. What the occupational health team might not think is that serious might be seen as a very serious issue by occupational health. So where possible, incorporation is preferable, but where it's not possible, like in a small farm where there is no clinic, it's still good enough to have at least something in terms of risk assessment. Remember, we are in an environment where not everybody has an occupational health clinic or access to occupational health services.
Absolutely. I think just something that, so I fully agree with you. I think something that just jumps to mind is that, for instance, under the biological hazards, if we look at fumigation, for instance, that's done at silo complexes or just in general in the grain environment, I think that obviously there are various risk aspects in the safety risk assessment, but I think incorporating biological monitoring, where the people that apply the chemicals and the substances obviously need to annually, or I think it's annually or biannually, need to go for biological monitoring. So I think that, incorporating that in your risk assessment, it obviously speaks to all the controls for the same risk.
Yes, that's correct. Yes. Okay. I don't know if you still have another question, Jared.
I don't see any questions at this stage, Doctor. So I think let's maybe continue for time's sake. Then, if there are any questions, I'll let you know.
Okay. And then on the next slide, the risk grading usually ranges between very mild to severe, sometimes very severe, depending on the type of risk matrix we are using. I'll show you an example of a risk matrix in the next slide or two. In terms of severe and high risk grading areas, normally controls have to be implemented immediately, and sometimes it may mean stopping the operation or stopping the work to address health and safety concerns before we proceed. Moderate hazards or risk needs to be managed within the shortest time possible, even if it's not immediately, but definitely not after a long time. So If we have, let's say, a moderate hazard, I would say within 3 to 6 months, it needs to be addressed before the next risk assessment is done. And then mild and very mild hazards or risks can be managed when time and resources allow, assuming that they do not compromise the safety. Risk matrix is designed to provide a uniform way of grading risks and being able to advise the management on risk management or risk control strategies. And then in terms of risk management, we employ what we call a hierarchy of controls. That's on the next slide. The first and the most effective control measure being elimination, where it is possible to totally eliminate the hazard. Elimination is the preferred control of choice. And then where we are unable to eliminate, we substitute. So say, for instance, where you use a certain chemical to perform a certain function, if there is another safer chemical that can be used, then we will substitute the dangerous chemical with a much safer chemical. And then we have engineering controls. Engineering controls means physically isolating the hazard and from exposure to employees. It can be re-engineering how a tool works or how an environment functions by physically creating barriers or designing features that will prevent injuries. Administrative controls is what we deal with every day, you know, rearranging shifts, assigning bodies to people who are maybe on light duty, scheduling certain tasks to be performed at a certain time when it's safer to do so. Like, for instance, allowing people to go home when we want to fumigate or fumigating at night. These are all administrative controls. Designing policies that govern how work is done, how certain procedures are performed, designing guidelines, disciplining people. These are all administrative controls. And the last and the least is the PPE. PPE is the least efficient form of control, sometimes the most expensive in certain instances. And this is usually a last resort that is considered once everything else has been tried and failed, or not effective for the type of the hazard or the risk we are facing. On the next slide, we talk about risk communication. This is a very important part that leads to many controls not being implemented in the workplace because the risk is not communicated efficiently or effectively. You need to know, as a risk manager, what must be communicated and what must not be communicated. So you need to know exactly what you must communicate with the management, what you must communicate with employees, with the employers, with the health and safety team, and with HR. And you need to know when to communicate it, preferably immediately after a risk assessment has been done and the report has been published. Sometimes even before the report is published, once you encounter a very serious risk or hazard, communication needs to be effected immediately. Where must it be done? It needs to be done at the right place within the working environment where it is confidential and safe to do so. Who must it be done to? Everybody that it applies to. Sometimes even the community, but the issue of the community is very controversial. As you know, sometimes it may lead to PR nightmares, and so the important thing is the first what you need to communicate what's important if you need to communicate with the community. Say, for instance, if you are fumigating the fields and there's a nearby community and you are worried that your organophosphate may be taken over by air into the neighboring community, you need to make them aware. they form part of the target population. Why must it be communicated? To facilitate effective and efficient risk management strategies, it needs to be communicated. If you do it, but you don't communicate it, nobody will know there is a hazard, nobody will know there is risk, and nothing might end up not being done. How must it be communicated? This goes into different types of communication. It can be written, it can be verbal in a recorded meeting, it can be electronic, it can be via media sometimes where it is necessary. And how much must be communicated? Definitely enough, not too much, not too little. Thank you very much. And then as we move on to the next slide, I just want to discuss the overlapping or the integration of risk assessment and medical surveillance. We are on our journey where we have done our risk assessment and we've done the risk management. Now we need to incorporate medical surveillance. We use the same information that we gathered during risk assessment to plan for medical surveillance. From this process, we'll develop a document called OREP, Occupational Risk Exposure Profile, which is a document that documents all the hazards that are faced within the working environment, properly graded and classified according to the areas, and we apply that to determine the type of medical surveillance we need for employees in order to manage the risk and hazard. The purpose, obviously, is to have an effective medical surveillance system that is targeted at minimizing the risk. So meaning where people are not exposed to chemicals, we do not have to include biological monitoring as part of our medical surveillance, because first of all, it will be a wasteful expenditure, and it will waste time as well and resources that we have. So we need to do medicals based on the hazards that we are facing within the working environment. Who is responsible for this? Again, the whole team. The occupational health and safety team. Occupational hygienists normally come in as consultants, but where they are available, they need to form part of the team to develop an OREP, and the clinic team also. And then once we have done the OREP, on the OREP, we'll grade or quantify our risk in terms of a risk matrix. And then on that risk matrix, we consider the probability and the impact of risk. Something that is rare and very severe, with a very potentially severe outcome, would be a minimum, would be a medium risk, obviously. Something that is almost certain that will happen with a severe outcome would be an extreme risk, or very high or very severe. For instance, if you cross the road, there is a risk that you might get bumped by a car. That's a given, you know. But if you cross, and the risk might be mild or moderate, depending on the amount of traffic. But crossing the road with eyes closed, the risk becomes extremely high. So meaning from the same hazard, the risk can vary depending on the circumstances. Or crossing the same road with earphones in your ears and not being able to hear cars coming, the same risk that was mild or moderate can become extreme. The risk surveillance matrix, medical surveillance matrix, sorry, is a document that we derive from our risk matrix and our OREPs that outlines the type of medical surveillance to be done in the whole company, the scheduling and the frequency. Meaning on that document, we'll be able to determine that HR staff will get a medical once every 2 years, and this is what they are exposed to, and these are the tests that we'll do on them. Similarly, the technical staff will get a medical every year, and they'll get a noise, they'll get a hearing test, They will get a lung function test because they're exposed to welding fumes, and they will get, say, vision screening because they do welding and it may damage their eyes. So it's a map that outlines the type of medical surveillance that will be done in a company for the whole company, all the departments, and it's visited regularly to make sure that it's up to date. Lastly, before we break, medical surveillance is a structured medical assessment that are performed at certain intervals or on occasions to minimize the risk of exposure to hazards and its impact. Why is it part of risk management? Medical surveillance is part of primary health care, which deals with prevention. So meaning if I test your sugar every day, I'm more likely to know when you develop diabetes before it causes harm on you, because this is part of screening that we do on a regular basis. And that ultimately manages to reduce the risk that you might not be able to come to work because of the same illness. So medical surveillance is part of risk assessment or risk management because we are able to detect illnesses early. We are able to detect noise-induced hearing loss much earlier, and we are able to prevent it because we can see certain employees that are at risk and we manage them before something bad happens. The purpose, obviously, is to manage risk, and also for the employees is to keep them healthy. It's a form of free healthcare that they get without having to pay a cent. So certain illnesses that are picked up during the process of medical illness are able to be managed early, and we are able to refer them early to treating doctors or physicians. The types of medical surveillance that are done in the workplace on the next slide. We have pre-employment medical surveillance that is done before an employee is hired, or at least within 30 days of employment. This is very important because sometimes we just hire them and we don't do this, and then we learn after 2 years that he has a noise-induced hearing loss, and it's difficult to determine whether we caused it or the previous guy caused it. So pre-employment is useful in such circumstances. Then we have what we call a pre-placement. Pre-placement means if a guy has been working in the kitchen and now we want him to go work in the bedroom, we will do a medical to make sure he's suitable to work in there. We cannot assume that working in the kitchen makes him fit to work in the dining room or work in the bedroom. So that's why we will do a pre-placement, even if there is a pre-employment or a periodic medical assessment in place. Remember, medical assessments are done based on the environment you work in and the exposures you encounter on a day-to-day basis. And then we have a concept of initial and baseline medical assessment. This is more or less a pre-employment, but initial medical assessment is what we do if we have failed to perform a medical within the first 30 days of employment. So meaning if you have hired John for like 6 months and you're only doing a medical in 6 months' time, it's no longer a pre-employment. It's called an initial employment. Baseline medical assessment is not necessarily a pre-employment or an initial. This is what the first medical assessment that is done within a certain environment. So all the pre-employments or pre-placements are considered to be baseline medical assessments because they were done before exposure. And this may even be done 10 years into the company when we transfer somebody from, let's say, the office into operations. Then we'll do a baseline medical assessment to make sure that he doesn't bring any illnesses or any effects of the previous employment into the new employment. Then we have the regular one that we always do, the periodic medical assessment, which is also called routine medical assessment, which is done on a regular basis. Sometimes it's done, most of the times it's done every year, but sometimes it's done when we can afford to, or when we have time, or when we finally listen to the clinic to do it. The return to work medical assessment, it's hardly ever done, but it's a very important type of medical assessment that is done if an employee has missed work for at least 5 consecutive days. A return to work medical assessment needs to be done to make sure that he is still fit to work within the department. If an employee has taken a prolonged leave of absence, whether it's annual leave or normal sick leave for more than 5 days, we have to do return to work medical assessment to make sure that he's still fit to work within that environment. And then we have what we call fitness to work medical assessment. Typically, this is what happens when you refer, Gerard, somebody to me to have a look at him. Essentially, it's a fitness to work assessment. Whether he has a high blood sugar or he has epilepsy or anything, any medical that is done on the spot, either by referral or as booked by the clinic, is called fitness to work medical assessment. And this includes all the clinic visits, even the emergency ones or the booked ones. They are all fitness to work medical assessments. Then we have the one that we do when people leave the employment, exit medical assessment, to make sure that we didn't cause any harm and to make sure that he doesn't come back after 2 years and say that we have caused harm. Finally, the medical surveillance process involves a normal consultation in the clinic or in a mobile clinic, which starts with an occupational health and safety history, clinical history, and then it will be followed by clinical examination, which we normally refer to as a head-to-toe examination, also focusing on certain areas or certain parts of the body.
Okay, bye.
Also followed by, also focusing on certain areas that might be affected by work. And then we have certain investigations that are done to support the medical assessment, including what we call side room tests. This is your blood glucose. This is your high blood pressure measurement. And then we have what we call legislated tests. This is your hearing test or audiometry. This is your lung function test or spirometry. This is your vision screening. And then we have what we call biological monitoring, which needs to be done sometimes when people are exposed to certain chemicals or substances. And then other tests that the doctor may feel are necessary to be done, like x-rays or certain laboratory tests. Multi-drug testing is part of bedside tests, by the way. We'll go into deeper details on it. And then we have certain tests like ECG, the heart test that we normally do for executive medicals. We have tests such as heat tolerance tests. And then we have specific questionnaires that we ask employees to fill in based on their exposure profile. The examples that I can mention is a hand and arm vibration questionnaire. There is an ergonomics questionnaire. A K10 questionnaire is a stress questionnaire that helps us to determine if an employee is very stressed and enable us to manage that effectively. An Epworth scale questionnaire is a questionnaire that we give to people who do shift work to determine if they are coping. Then we have working at heights questionnaire, and then we have confined spaces and so forth. Medical surveillance, medical bedside testing that we do is glucose testing, hemoglobin, cholesterol, and urine dipstick. Urine dipstick can help us identify various illnesses such as kidney disease, blood glucose, blood in urine, as may be caused by certain work-related problems. If we move on to the next slides, next two slides, Next slide and the next one. Multi-drug testing. The important thing to do, which we normally omit in multi-drug testing, is that first you must have a drug policy in place. Legally speaking, you cannot do multi-drug testing if you don't have a drug policy. You can if you want to, but it won't stand in court. And I'll be more than happy to answer a few questions on this. So first you need to have a drug policy, and the role of the clinic is to enforce the drug policy that is in existence. It's on the next slide, Annelien. And then first, the process, next one, the process must be outlined to the employee before you test them. You tell them that I'm going to test you for drugs because we have a policy that says we don't tolerate drugs, and this is what we are going to do, 1, 2, 3, 4, before you test. And then you get a consent. The employee must sign that they are agreeing to be tested for drugs. Whether they are suspected or it's a routine, they must sign first to give you consent. If you do it without consent, it will not stand in court. Then before and after you perform the test, you need to interpret and explain the results. What does one line mean? What does 2 lines mean? And if we find you to have cannabis in your urine, what are we going to do? What's the procedure that will be followed? This is done before you do the test. Then after you do the test, you read the results to the employee, and then you follow the procedure that you have explained. The issue of cannabis, I think it's a highly contested issue. Most of the times, we will say that we have a zero tolerance against this. And most companies believe that quoting zero tolerance means we can do a drug test anytime we want, and we can do whatever we want for people or on people that have been found to be positive, to test positive on drugs. Unfortunately, that's not how it works. As we know, the law now allows us to smoke cannabis. By us, I don't mean I smoke, but I'm just saying it allows us to smoke cannabis at the comfort of our homes or even plant. It's still illegal to sell cannabis, obviously, and it is still illegal to find an employee in possession of cannabis in the workplace or find him smoking. So we need to separate the illegality of cannabis consumption and the fact that a person simply smokes cannabis. A positive urine test simply means that this person smokes cannabis. It doesn't mean the person is high. It doesn't mean that the person brought cannabis to work. We need to have evidence, and we need to properly charge for an appropriate charge. If you want to charge him for cannabis possession, it cannot be called cannabis consumption. Possession is possession, consumption is consumption, and consumption might be allowed. If you want to charge him for intoxication, intoxication means there are signs that prove that at the time of when he was caught, the employee was intoxicated from cannabis. If it's just a routine urine test that is positive, unfortunately, it cannot be judged as intoxication or possession. And the other important thing is the law does not restrict us from designing policies that prevent our drivers or important or sensitive or high-risk employees to consume cannabis. If you have it on policy that drivers shall not be found positive on cannabis, and they know the policy and they have okayed it and their unions have signed on it, then you can prosecute them on contravention of that policy. But the most important thing here is that there must be a policy. I don't know if we want to break, or I can just finish the 3 or 4 slides that are left before break. Gerard?
I don't know what the general consensus is, but maybe we should take a bit of a break and just be back at 1:45, then we can take it from there. Because I think then we've had a break, then we can continue. I think that's probably the best.
All right.
Okay, can we take a break? Then we'll be back at 11:15.
All right. Let's do that. Thank you.
Thanks.